Okay, welcome to the spring course here that we have for, let's make sure I get the name of this right. Radiation dosimetry and instrumentation. We're going to be covering a number of topics here, and we'll have a number of problems where we're going to have to go through and work out exactly how we come up with certain monitor unit computations. And we're going to have different settings in which we would compute what the monitor units are. We're going to get to all of that. I figure probably the most boring chapter for everybody is going to be the QA chapter. As the old joke goes, it's not QA, it's QA. But the reason that we have quality assurance is to make sure that we're not missing something. We want to make sure that the machines, regardless if it's the planning system or if it happens to be the accelerator itself, we need to make sure that those machines are calculating as correctly as possible. And we also want to make sure that we're delivering the dose that we say that we are, because if we're not, that's going to end up being a real problem for everybody concerned, patient, the clinic, everybody. And so how does one go about making sure that the machines are doing what they're supposed to be doing, that the doses that are computed by the calculation box are indeed accurate? And this is where we have to go through and we have to see what the steps are in order to make sure that we can make the claim that yes, the machine is doing exactly what we need it to do. So you may have heard of QA. It not only extends to IMRT plans, and that's really where you see a lot of it, but you also have QA for machines, for the accelerators, for the calculation boxes and whatnot, because they happen on a regular basis, and usually the physicist is going to be the one that's in charge of all of that. So obviously here I'm not interested in making you into a physicist, but what I do need you to understand is the purpose of why we do these kinds of things. So some of the details here we'll kind of gloss over, because quite frankly, I think having you look or memorize a bunch of these details are not really going to aid in your understanding. So let's take a look here at what all we have going on. One pretty germane paragraph here that we need to bear in mind is that the major reason for the lack of commitment to QA by many institutions is financial. Basically, how much money does a clinic have in order to be able to employ somebody, in order to be able to say, yeah, everything's working fine, this is fine, everything's fine? Because it doesn't take much for a plan or a machine to go bad. And then once you start delivering plans that are going to cause a problem, particularly one that you're not monitoring, that is a great way to get a lawyer involved and to make sure that your clinic will never recover from a potential lawsuit. So a lot of times the QA process is there to make sure that the ship doesn't sink. It may bog things down, it may take a little bit of time and whatnot, but that's why it's there. It's to protect everybody. And so it's very important. And so you have several different agencies here that are set up. You've got QA programs that are proposed by the ACR, ASTRO, AAPM, and they're going to incorporate certain standards and criteria from National Council on Radiation Protection and Measurements, NCRP, ICRU, and many other acronyms we can throw around here, NRC, JCAHO, that kind of thing. So again, part of this paragraph here, according to the analysis that is performed by Peters, the total cost of a QA program in radiation therapy amounts to about 3% of the annual billing. It's not insignificant, but boy, I'd rather pay 3% of something rather than turn around and have to pay millions of dollars because of a mistake that could have been prevented. Not to mention the toll that it'll take on a patient. So let's take a look here at goals. You've got something here that is called the Blue Book, and it is the purpose is the objective systematic monitoring of the quality and appropriateness of patient care. Basically, it's how do we go through and make sure that we are doing the best that we can for patients and trying to prevent as many mistakes as possible. There's also a new book called Safety is No Accident. I think I'm going to have a link to that there in the course if you kind of want to go through it and just kind of see what all it talks about and what people's roles are. Now, the next section here, physics staffing. This is an important one. The Blue Book generally has specific recommendations here for minimum personnel. And I think to some degree, a lot of this can change, particularly on the type of patients that you see coming through the clinic. Certainly the numbers, staffing can change. Obviously, you see the recommendations there, you know, for the radiation oncologist, it's recommended minimum at least one per facility because you have to have their name on the license in order to be able to go forward to treat it all. A chief medical physicist, you need one person there. Department manager, usually your medical dosimetrist, and I don't know if these numbers still hold. I have a question about that. One per 250 patients, depending on the complexity and the demands made by either physics or the physician. I think that number could technically be lowered, just simply because when you're starting to pay that much attention to something, you can't churn out plans as quickly as if you as if they, you know, you were planning, you know, 20 years ago. So that's something else to think about. Radiation therapist, you normally have about 1 per 90 patients treated annually. Again, I suspect that that number may now be a little bit lower. Obviously, if you have brachytherapy, depending, I'm not exactly sure. The brachytherapy stuff hasn't really changed remarkably, I think, over the past 5 years. But I think since this has come out, it's probably a reasonable guideline, 1 per 100 brachytherapy patients. And then the mold room technologist, generally, I think most things are done now with MLCs, although you do have an electron block. And if you guys ever get a chance to cut an electron block, I would encourage you to do it because electron blocks are not easy. And depending on where you go, that may be something that is assigned to you. So that is something I would definitely consider if you get the opportunity to do it. You have some recommendations here regarding staffing for different types of procedures. Again, I don't know exactly who all is still using cobalt units here in the States. I think that's probably been sent out a lot to perhaps developing countries. And even there, I'm not exactly sure how common they are. Same thing with orthovoltage and other things. So obviously it's not to sneeze at any of this, but sometimes the technology here in the US, we are looking predominantly at 3D planning. We're looking at IMRT planning, and then certain specialties beyond that, some of which we'll go over in this particular course. Here you have several different diagrams here of how things can be done in the clinic. A radiation oncologist, in my opinion, should never be left to plan his own treatment. They can prescribe certainly, and they know sort of what modality they might want to go with, but they shouldn't be in charge of putting together the plan in your planning system. They don't know enough in order to be able to do that. Adding in a dosimetrist such as myself will help, but as always, it is not optimal because you need somebody else who is familiar with the planning system and what it's capable of, and double checking to make sure you haven't missed anything. They need to be involved too, to check to see what's going on. If you don't have that check, you're running a real risk of missing something, and you don't want to do that. Here are the qualifications if you decide to become a physicist. Obviously, they have changed. Most by now will have gone through some sort of, or are going to be going through, and gotten their master's degree, maybe a doctorate, and then going on to do some sort of residency. A residency is really sort of where they get the hands-on look for certain things, and to have a physicist that's been hands-on, it's going to be worth a lot more than just somebody who did self-study and has worked their way into a clinic. You can see certain roles and responsibilities of each. The equipment, treatment planning, dosimetry, radiation protection, so on and so forth. So everybody has a certain role that they need to play, and physics should not be exempt from any part of the planning process, because they know, they should know more about the system than just about anybody else. So now, as far as the equipment is concerned, you guys, when you're treating, you're going to be using external beam units mostly. Most of these units are going to be having linear accelerators, any energy range. It says 4 to 6 MV. Most likely you're going to have machines that are some combination of 4, 6, 10, 15, 18 MV, something along those lines. It depends on the site as far as which energy they're going to use. Obviously, the greater the energy for photons, the greater the penetration you're going to get. The closer they are to the surface of the skin, obviously the less energy you want to hit with, and in terms of photons and sometimes electrons, with the fact that they fall off so fairly quickly compared to photons. Sometimes having electron beams is going to be useful. And so you'll have a myriad of electron beams, usually starting with a 6, working their way up to about 20. I have never seen a 20 MeV electron beam used in the clinic yet.